Thank you. Thank you to Dr. Prerna also for the kind introduction. Very good afternoon to all our esteemed panel and everybody attending this session. So mine is the most basic topic of all, and it is about what sutures can be used in oculoplastics, the instruments that we use, and the principles of suturing. So the main point of suturing is to close the surgical wound so that they heal by primary intention. And these are the materials that are required for suturing. The ideal suturing material should have a good strength, be able to knot well, and not be carcinogenic. We all know the basic classification of sutures based on their source, whether they're absorbable, non-absorbable, mono and multifilament. And these are the examples, and we're all aware of this. This is very basic. So the advantages of a monofilament suture is that they have smooth surfaces and less trauma, but they can cause nicks or crimps, which can cause easy breakage. And the multifilament ones have good strength, and the only disadvantage is that they have more tissue trauma. So the body has a natural response to sutures, and the natural absorbable ones, they undergo proteolytic degradation with more of a tissue response. The synthetic absorbable ones undergo hydrolysis with a milder response, and the non-absorbable ones, they get walled off or encapsulated with an acellular response. So these are things which are very commonly used by oculoplastic surgeons, Vicryl, Prolene, nylon. And the suture sizes, 1-0 is being the largest and 11-0 being the finest. We don't generally use 11-0 in our oculoplastic practice. So Vicryl is probably one of the most commonly used, especially for the subcutaneous tissues. Many would like to use it for the skin as well, but that varies between surgeon to surgeon. Prolene again used mainly in the skin. Nylon as well, and silk is used, the bigger ones are used as traction sutures, mainly rather than for closing wounds. So it's important to know how to read a suture pack. So most commonly what we read in the suture pack is the gauge of the suture, the needle, whether it is cutting, reverse cutting, and the expiry date. So coming to needles, the ideal needle should have a smaller diameter, but obviously that is based on what you need the needle for, and it should be resistant to corrosion. So these are the parts of a needle, and they are basically classified based on this, whether they are swashed or eyed. The eyed needles require sutures to be threaded through them, and we generally used curved needles in oculoplastics, and they also vary depending on the point. So the ones we generally use are the reverse cutting ones, and the sutures should be of appropriate size. So that is based on the kind of incision that you have to close and how much tension is required. So the needle and the suture depends on that. And the instruments that we use are suture tying forceps, tooth forceps to hold skin and dermis, plain forceps sometimes to hold the suture itself, needle holders, Westcott scissors to cut the suture. So coming to the main point of this talk, that is principles of suturing. So one thing is that we should avoid retrieving the needle from the tissue by the tip of the needle, because that causes blunting of the needle tip, and with subsequent passes of the needle, it can cause more damage to the tissue than good. And the suture passes should be of equal depth on both the sides so as to oppose the wound well, and the needle should exit perpendicularly to the tissue surface. So this is how that looks. Another thing is the needle should be passed from the movable side to the non-movable side. So for example, while suturing grafts like this hard palate graft, it's better to move the needle from the conjunctiva to the graft rather than the other way around. And it's important to align the tissues well, so that eventually there is a elimination of dead space as well as you suture in layers, because when you remove tumors like this, they can cause a lot of dead space to be left behind, which can lead to accumulation of blood and serous fluid. The absorbable sutures that we use commonly are plain catgut, which is a good suture to use for something like a fascinella servet procedure, so for the conjunctiva, and this absorbs as well, so you need not remove it. And vicryl, the bigger vicryl sutures can be used for suturing the thigh, like in a fascia lata surgery. The smaller ones can be used to close DCR sutures. And non-absorbable sutures are silk and proline and nylon that we use. So here you can see how silk is being used to create a fornix, and proline and nylon are also used, the smaller ones, for closing skin and to give good subcuticular closure as well. And this is where you can see silk being used for traction as well as to close a tarsorrhaphy. And silk also has a very good tensile strength, so the thicker ones are used to approximate wounds at the lid margins. And special needle would be the large needles, which are again used in fornix formation and other places where you need periosteal bites to be taken, like a lateral tarsal strip. So these are larger needles which are much easier to pass through the periosteum. So this is the ideal suture placement. So with resulting in a slight eversion of the wound edge, with the knot away from the line of incision, and thus the margins don't override. And to ensure a watertight closure, it's important that the length of the suture is equal to the distance between the sutures as well. So sometimes you can have a dog ear which may form. So when there is excess tissue left on one side, so that is how you lift up the tissue and remove that piece so that you can close the edges of the wound without causing a dog ear. And knot tying is another art. So the knot has three parts: the loop, the knot, and the ears of the knot, which is cut. And the traction should be maintained at one end of the suture, to not only to prevent loosening but also to not waste the suture. So you can push down one end so that the other end remains small. And extra throws do not actually add strength to a properly tied knot. However, extra throws are required in sutures like monofilament proline, where if you don't put extra knots, it can slip. So suture removal is generally done within 7 days, but you can alter it depending on the wound and the patient. Sometimes it's useful to give vitamin C supplements to patients to improve wound healing. So simple interrupted sutures, I'm sure everybody knows about, and continuous sutures as well. I'll just demonstrate it here. So if you can see on the model, that is a vicryl suture 50, and you can see it is on either side of the wound. It's equal on both the sides, and the throws are taken and it is tied, and eventually the knot will be brought on one side of the wound. And you can see in this case we are just putting interrupted sutures. So this is good for closing conjunctiva. That is done with a vicryl suture itself. So that is a simple interrupted suture. Now this is for the continuous suture. So you can see it is taken at one end. It will be tied at one end, and then it is equally passed on both the sides of the incision. Without passing it through the loop, so that you get continuous non-interlocking sutures. And this is an example here of when you're closing skin, you can take continuously without passing the needle through the loop. That is a continuous suture. Now, horizontal and vertical mattress sutures, we use them sometimes to get a better strength of the wounds. So in the horizontal one, it is passed from one end to the other, and then it is horizontally passed on the same side, like that, and it comes out through the other end. And this is tied down. And in the vertical, it is taken from one end, and then it goes to the other end. And it's vertical, so it comes back through this end, and it is tied in the end in which it was started. So running locked sutures, it's just like a continuous, but in this, the needle is passed through the loop as well. So here you can see it is pulled through and it is passed through the loop. Right. So subcuticular sutures are another nice and elegant suture. It is basically passed in the subcutaneous portion at the wound edges. So it's passed on either edge like that without involving the skin. And finally, when you pull the edges, it gives a nice watertight closure and an aesthetic closure as well. Buried sutures are started the other way. It starts from the inside of the suture, so that inside of the wound to prevent exposure of the knot. So it's good for conjunctival suturing. So that's the end of my talk. I think I overshot by a couple of minutes, but that was as basic as I could